Here, nice to see all these budding, fresh faces in front of us. And as we all sit here as clinical psychologists, we would always say whatever the base that we have gained in this subject is typically from PRAJYOTI, the work culture and the educational standards that PRAJYOTI sets for each student is extremely blissful, and that standards, I hope we all have grown to those standards. So as all the panelists sit here to set examples in their fields of expertise, I would like to put a few words on the mental health statistics in India. If you look at the cases that are happening in India, it's almost the psychotherapy, a client comes to psychotherapy, either it is direct, or it is referred, or it is forced, or somebody comes to know what is psychotherapy. So we look into several areas, and the 5 areas that will be covered will be child and adolescent psychotherapies, trauma-based psychotherapies, online psychotherapies, mindfulness-based, and of course the most important, the legal and ethical aspects of psychotherapy. Shall we start the discussion? Conducting psychotherapy with adults is much easier, but with child and adolescents is a heavy task. So let's start our discussion with the psychotherapies in children and adolescents, the recent trends, their experiences, special events that has happened, and contemporary issues that is happening in that field. So I pass on the mic to.
Good afternoon, everyone. Thank you. So my experience and expertise for the past 4-5 years have been primarily in child and adolescents. So while working as a consultant in the child and adolescent unit, first I'll just try to give you an idea of the cases that we see, the experiences that we've had, that I've had, and the kind of interventions, the therapeutic approaches that we take up. So I'll briefly go into the kind of cases that we see. So from a very young age, from infancy till about age of maybe less than 10 years probably, what we can see is in the early stages, at least infancy and early childhood, we can see a lot of cases being referred to us for autism spectrum disorder, attention deficit and hyperactivity disorder, and very much what we see is also developmental delay and intellectual delays basically. So with such cases, the age range is, I think, widespread. It starts from a very young age where developmental milestones from 3 months or 6 months is not achieved, and from there on what we see is maybe children who are hyperactive, who are brought to us, or they have difficulties in maintaining eye contact or social interaction. So again, autism spectrum disorders come in. So when we talk about this age group also, a large number of them is also behavioral issues ranging from ODD, that is oppositional defiant disorder, to conduct disorder as well. So anger issues, temper tantrums, behavioral issues, disruptive behaviors, this is what we see. Also primarily I have dealt with a lot of assessments where we work with children who have intellectual delays as well as learning disorders. So we get a lot of cases with specific learning disability, and their assessment is very key to our unit, because when we do these assessments, it is also it's very important for them for their 10th grade and their 12th grade exams. So we get a lot of influx of patients around that time, to assess. But also prior to that also, when parents recognize that children have issues, they bring us and either I take up children who have these SLD and we do the remedial training. Otherwise, I'm also very keen on referring them to a remedial trainer. It could be there is a person who was regularly available for us, so we would send them for remedial coaching as well. moving on from there, if you look at adolescence, what I've seen largely is a lot of emotional disturbances that we see. So that can come up from anxieties, depression, social anxiety, substance use, addiction, shyness. This is all commonly seen in children. And then I think when in further extent, we can look at cases where children have parents who are undergoing a divorce, separation, maybe abuse within the family. So again, maybe once in a while, maybe I may have encountered a case where there has been sexual abuse. So we are very keen on reporting that to the authorities. So that also comes in. And then I think primarily working in a hospital setup, I have liaised with a number of departments. So working in child has, I formed a lot of connections with a lot of departments. So this has ranged from neurology to pediatric, the pediatric unit in our hospital, rheumatology, because rheumatology, if you see, we see a lot of psychosomatic pain, children with psychosomatic pain or somatoform disorders. So they come to us and we see them regularly. Then there is also children who come from the gastroenterology department. So sometimes children may have, in an instance of impulsivity, may have consumed poisonous substances, and so they are referred to us for therapy. So this is the wide-ranging, I guess, number of cases that I see. And if I go into the therapeutic intervention, I think it's starting again from a very young age. What we see is behavioral interventions are largely done with children who have autism spectrum disorders, ADHD, with intellectual developmental, I guess, disability. It refers, I mean, we have to refer them for speech therapy, for occupational therapy. We send them to, again, a wide range of other therapies, not only us. So that is done. Then I think children with a little more emotional issues, we again work with forming a good therapeutic alliance, which is very critical in children. And I think we have worked with children who have had these emotional issues, and the therapies that I've done include play therapy, I think maybe CBT definitely. We have also, I think, done a fair share of DBT among those children who have had issues with their emotional balance. Then I think a huge portion of our work also is with parents. So I think one of the a critical thought that I've had is that it's always easy to deal with the child, because you can, once you establish alliance with them, it's very easy. But the parents are also a very critical component of dealing with children. So I have had very maybe anxious parents, I would say, who come into the picture constantly and want to know and want to interfere. So being a therapist in this setup with children also, you have to know how to deal with parents, and I guess their anxiety is understood. And so PMT, that is parent management, is also a huge part. So and I think along with that comes family therapy. Along with that, even I think amongst parents itself there are issues, so couple therapy is also critical. And okay, one case, another set of clients we see regularly is also children with tic disorder. So I enjoy working with tic disorder because it is, if you do HRT, that is habit reversal training with them for maybe 1 or 2 sessions, it's a big improvement. And so it's wonderful to see that change in children. I guess these are some of the things that I've done and seen in my years of expertise. Should I discuss further?
It would be good if you can share your workload. How much workload you get and how much time you are able to spend for each client.
Right. So working in a hospital, I think numbers are very important. So if you don't show by the end of the month that you've made income, it becomes a problem. So we do see a lot of cases, and sometimes manpower is limited. So if we have a child, I think I try to spend at least an hour with the child to see what the case history, and try to do at least basic assessments. I think if it is IQ and an SLD together, it takes about 3 hours for a child. So we don't have that kind of resources, but unfortunately that's the state. We have to spend about 3 hours and do an IQ assessment and an SLD assessment, finish up the report and give it to it then and there. Because the need of the hour is that they, a lot of clients come in for this, and I think it has impacted us because I find it very hard to do a good job with these children, because you have 3 hours of time, you need to give them a report, you do an IQ assessment in 1.5 hours, maybe 1 hour, and then an SLD assessment is quickly done. But all of these require time, but unfortunately our system is such that we don't have that time, nor do we have the resources, so we kind of hurry up in the process. So definitely the workload is significantly high. Some of the challenges also that we have faced is always, I guess, getting people to work, consistently with children. I think now that I've stepped out of child unit and I work with adults as well, I think it's hard to find people who primarily work with children also, because I think it's hard to work with children. Maybe that's why so I've seen my MPhil students itself, step away, because when they hear it's a child case, they all run away. So they don't want to take it up. But then I find the greatest joy in working with children is if I have seen a child with maybe, autism spectrum disorder symptoms possibly. I see them for a while and I send them for the various therapies, adjunct therapies. And maybe in a month or two, when the parents come back, there is a big change. So when you work with children who are less than 3 or 4 years, I don't know, I think their brain is in such a way that they, synaptic plasticity is huge. So I feel like there is a big change when working with children. So many people don't, I think, see that, and I think I've had a great time, spending with children. Some of the challenges, I guess, I think dealing with parents who are anxious. I think they mean well, but then when they come intruding, it's very difficult. So I think that requires a lot of effort and patience. Another challenge is, I think, building therapeutic alliance with children. So we are often, I think, plagued with this thought that we are not doing enough. So when we spend 1 hour, it doesn't lead up to anything, or am I doing enough? But I think this initial few hours with a child is crucial, because once you form a connection, it's, I think, very easy to be on their side, So I think that is a challenge. Then I think again, parental expectations come back to me, because in the current scenario, the kind of children we see now is vastly different, I think, from the children who we may have seen 10 years ago, because nowadays children grow up with social media and with I think phones in their hand from the beginning. So now we are seeing a different set of children coming to us. So these children have, I think, worries about how they appear to others. I think they have a worry to put themselves out there. There is a concept of FOMO. Everybody wants to put their life out in social media for everybody to see. So when you see your friends going out on trips, you want to go on trips. So I think there is the expectations from the children nowadays is very different. So I think I've had a good, it's challenging, but I find it interesting also that I have molded myself in a way to address these issues also, because times are very different from back then. So I think we have to start considering how social media, how technological advancements have come into children's lives these days, even adolescents, and have caused great problems. Definitely there's a lot of benefits, but problems are also there.
Thank you, Shruti. So whenever you hear such kind of things for the students, you never think that you are far away from all these topics. What you learn as your paper in developmental psychology, the psychometric tests that you learn, that is the basis for all these things. So don't take those subjects lightly. Those textbook becomes your Bible when you start practicing. So any kind of basic IQ test, evaluations, understanding the norms, the developmental psychology textbook, all those things are important. So those things are not very far away from child and adolescent clinical psychology topics. So take your course material seriously, because whatever you learn in degree and PG, that comes at your hand when you come for an MPhil course or to a professional course. And moving on to the next topic, trauma-based psychotherapies is a new area of intervention. So Sri Lakshmi will talk extensively on it, what is happening in and around the trauma-based therapies, the trends, challenges, and the burden in trauma-based therapies.
Good afternoon, everyone. So like Manu was mentioning, trauma is a thing now. We'll see that next to all the, or a lot of people's name, they claim to be trauma-informed therapists or trauma-focused therapists. But it is sad to know that it's not taken in the right sense, you know. Knowing about trauma is not being trauma-informed. Or seeing a client with trauma is not doing a trauma-focused work itself. So what exactly is trauma? Previously, we used to attach a lot of significance to the traumatic event. So if someone has met with a car accident, then that event was given a lot of importance. But the understanding of trauma has evolved, and it's a field that's seeing a lot of changes, and a lot of research and work is going on right now. Trauma is not as much about the event, but it is about the experience that the person has from that event. So traumatic events are not very unusual events, they are usual events, but what makes them traumatic or what makes them unusual is the experience that it creates for our nervous system. So now PTSD was the only diagnosis that was there earlier. Now complex PTSD has come. Complex trauma is something that we see quite a bit right now. So what is complex trauma? So when we speak about PTSD, we talk about something called a big T trauma or a single incident trauma. But when there are multiple minor traumatic events happening over a period of time, then it mounts to complex trauma. So that includes attachment injuries and things like that. And now understanding of trauma also includes things like neglect, poverty, all that also comes under trauma. So a child who is abused by a caregiver is as traumatized as a child who does not have presence of a caregiver in their life as well. So neglect will also harm the child as much as a physical abuse would harm the child. Now, dealing with trauma, we talk about trauma-informed and trauma-focused work. So being trauma-informed is about how you do your intervention. So it is the process of the work that we do. So when we, if I say that I'm a trauma-informed therapist, that means I understand or I can recognize trauma, I can recognize the symptoms of trauma, and I also, as much as I understand that from a client, I'm also informed about my traumatic experiences and how my nervous system shifts as I connect with my clients who have their trauma, who is dealing with their trauma. So trauma-informed is a perspective, or it is a framework from which we work. Trauma-focused is where we deal with the traumatic events. So we go into processing work or exposure. So trauma-focused CBT is something that is there. EMDR is another field that's, you know, that's widely used for processing work in trauma. Then prolonged exposure is another evidence-based that is there. So in all personality disorder works, especially dealing with people with borderline personality disorders, trauma is something that requires special attention. Because when a child goes through multiple incidents of trauma, what happens is that is a formative years when their brain gets, brain wiring is happening. So we learn about emotional regulation when somebody, a caregiver is able to show that to us, or when I have a dysregulation, when my caregiver helps me to regulate my nervous system, that is how I learn to do it. So when the caregiver itself becomes the person who is inducing trauma, or absence of such a person leads vast damage to the brain of the child. And they can grow up to show symptoms which mimic ADHD, because what happens in trauma is the safety is challenged. So we start believing that no one is safe, and the world is not safe. So you're always hyper-vigilant of what's going on around you. So you cannot concentrate on your studies, so your academics gets affected. You cannot form relationship with others because you do not trust anyone. And you cannot regulate your emotions, because nobody has taught you how to regulate your emotions. So these are the sort of clients that we see on a daily basis. Since I am now focusing, my work is mostly with clients with trauma, there's a huge demand for this, trauma specialization and trauma-focused work, but it's a very sensitive area also because dissociation is something that's very common in people with trauma. So we do not directly go and address trauma in clients. Sometimes it can take up to 6 months of regulation works or things like that for us to even reach to touch the traumatic experiences. But that's a very promising and a very satisfying job, I say, because disorganization of self is something that we see in clients with trauma. And after the work, if you ask them what has changed, they say my life has changed because you help the parts that have been disorganized to come together and get a cohesive sense of self. So that is in short about trauma and the work that's going on in
Thank you, Shruti. So yeah, putting light or throwing light to somebody's life is so satisfying, or it's like giving a new birth to people. So conveying therapies directly is usually what's being done, but COVID period has brought in the trend of online therapies or online consultations. So Shareka will talk about it in detail, the online and offline kind of therapies, the challenges and what work she is doing on.
Good afternoon, everyone. First of all, thanks for having me invited here. And this is a very special moment, being back to your foundation of your college. So I'm sure every one of us know the technological advancements and the kind of therapies that's available. But I think a more focus on the usage of technology has come up, brought into light, especially during the COVID. I think a lot of stigma, a lot of barriers has been erased in reaching out to people. A lot of mental health awareness has come into place, especially during the COVID-19. So if you look at it as a practitioner, majority of the cases that has reached out, like if I say there were a number of cases that I was seeing online before COVID was less compared to after. Now if you look at it in a day of my practice, at least 2 or 3 sessions would be online alongside the face-to-face session also. So what has really actually happened with the technological advancements is that online and offline, both are going hand in hand. The kind of boundaries, the stigma, people finding it difficult to come to a clinic or meet a mental health professional has been completely taken away, and that given a lot of access. Not only that, it also took the stigma away that it is not to a particular group of people that mental health issues are actually seen. Almost, I mean, COVID-19, the blessing of COVID-19 is that everybody who's stuck inside the house starts feeling anxiety and stress. And even without having to go to a hospital or a clinic to meet a professional, it just helped, this technological advancement just helped people to reach out, plan an appointment. It became a lot of apps came into play to even fix an appointment. Having an integrated approach with all the other specialists alongside one platform. That was actually made possible with the technological advancements. The scheduling of time and the kind of decisions of this, and even the kind of barriers of being of different places or country is also being taken away. Now, so what are the technological advancements we focus? There is teletherapy, there is video conferencing, there are kind of apps that monitor your kind of mood, your thought diary, your kind of daily activities, behavioral activations. A lot of apps are even if you look at the kind of screen addictions, new apps are coming in place to actually monitor both the adult and the children. So that is also being helped. And based on the kind of place you have, you can also choose what you want to actually monitor and be in touch with the people. So technology definitely has helped him to take the barrier off, both in the case of adult and child. But there are limitations also. So before that, let me also say that technology also helped with diagnosis as well as the assessment part. It made it so easy that the assessment doesn't take so much of time. The availability of materials across the apps and the kind of technology has given a lot of help in reaching out to people. At the same time, there are limitations also if you have to look at the technological advancement. If you take away the face-to-face therapy, which is a traditional form of, there are studies which has been compared with the online as well as the face-to-face. So the study says that a hybrid mode would be better. Now, why is that? Because a lot of things that we can assess through a face-to-face session is not completely possible with the online session. And a hybrid mode is suggested because having a touch with a person, especially in the setting, let's say setting of a therapy, when it is, you have a better control over the setting when you have to have a face-to-face. Now, whereas when you get on to an online therapy, you have no control over the kind of the patient and their situation, the environment with which. So it can even go up to the kind of confidentiality and privacy and the kind of interactions. If you look at it, only you will have to even select the kind of population which are, availing for the online therapy, especially with kids also. A more driven, more disciplined, more responsible, and who can follow it through the kind of online session would be most appropriate and it will give more results compared to the face-to-face. Because when you have face-to-face, you are able to drive them much more than compared to the online when you see that the person is going down. Also with the assessments and the kind of body languages, the therapeutic relationship is also kind of a limitation which says that the studies have done between the online and the offline. So definitely it do have. Another problem which has come in is also the kind of main thing that has come across is also screen addiction. So technology has taken over the kind of screen addiction with adult to children to everybody. Even if a single minute that you have, the first thing that we go back onto is the screen, and we cannot be completely off screen. So giving online therapy, those kind of things has the limitations, and it also given to it. Especially with kids, when you do therapy with the kids, it becomes difficult in parent involvement when you have an online session. Whereas on a face-to-face, you have a better control, and parent involvement is also much more on a face-to-face. Apart from that, the kind of human touch and the relationship has also been changing because the artificial intelligence has been taking over, the chat boxes are there. The therapist becomes a computer and you start getting to see as your therapy is a computer. So that is something which has been losing and it is also being very threatening. Now, when I said about this, people coming, a flood of people coming in for online therapy, we also, as a therapist, as a professional, the difficulty or the challenge that we face is the overload of cases that is coming by. The technology projects as our profiles across all the social networking sites, and people are able to credentially look up to you and reach out to you. But the number of cases are overloaded and it's flooding. So sometimes it's very difficult. In my practice, if I have to say that, if one of my cases is a face-to-face, the next would be an online. So by the time I finish my face-to-face, I have to switch into the kind of online. And sometimes you're exhausted because there's not even a span of time that you get to breathe and the other person is already on. And so the burnout level as a therapist when we do online is much compared to that of the face-to-face. So if you look at it, there is a lot of difficulties as well as a good part of having online and offline. So a better recommended kind of therapy would be a hybrid. That means especially if you can see them in a few sessions, build alliance and then probably switch into your online session, that would be great. Also another thing is, a lot of people, especially when it comes to a marital or a couple relationship, people started choosing your companion from the online platforms. So when you have to address the issues, it's more related to the online platform issues or the kind of online communication which they had before marriage or in getting to know each other. So it becomes more difficult, especially we'll have to deal with the online kind of restrictions and the communication that has come in the real life reality. But I can tell you something is that upcoming students, upcoming professionals, with the overload of the kind of people, especially in India, you got a high scope to actually reach out and help. So this overload is a blessing, but if you're really licensed and passionate to do about it, then nothing like it. And the difficulty what we're facing currently is also with the overload is people moving out of India for a green pasture. But if you're really focusing on it, you can completely make out your way in online or offline which best suits you in your comfortable space. Thank you.
Thank you, Shreka. Next, we would hear few words on mindfulness-based therapies, and I welcome Vidya to speak on it.
Actually, BBC had done a study on how to improve or increase the happiness level among people. There were two groups, like experimental group. The experimental group was asked to do a 5 minutes meditation, mindfulness meditation for a period of 1 month. The second task was to write 3 things that they were gratitude. They had a sense of gratitude, 3 things, and write a gratitude letter. And the third thing was to do an act of kindness a day. The results showed that the experimental group had significantly higher levels of happiness than when compared to treatment as usual group. This itself shows that mindfulness is something which, if it is practiced, it will increase our well-being, mental well-being, general psychological issues. Will solve the general psychological issues. So what is mindfulness? It's just being in the present. It has got few factors which we have to focus is it should be in the present. It is something which is related to our attention, not our thinking process. We should have a sense of openness and curiosity towards it rather than running away from our problems or fighting against it. We take a non-judgmental stance. And fifth quality of mindfulness is that when we practice mindfulness, we use our breath as an anchor, so that whenever any bad thoughts or anything that is affecting from the past comes, it will not create any guilt, or if something from the future that creates anxiety comes, we are focused on the present. So my take-home message is that since mindfulness meditation and mindfulness should be practiced by everyone, so that we will be in the present, rather than we will be in the present with the present emotion, rather than being affected by the past or the future anxieties. And regarding the efficacy, this mindfulness is found to be very effective in relapse prevention of depression, and among children this has found to be very effective in their study skills, examination performance, and we have to understand one major thing is that our life provides both. At the same time, it's amazing and terrible. We have joy at one stance. On the other hand, we have despair, we have success, we have failure. But at this present moment, we can be very happy in one present moment. At the same time, we can be very sad when we think about something that has happened, or very anxious when we think about something regarding future. So it is one of the reasons for this is that our mind has a natural tendency, or it naturally creates psychological suffering. So from this third wave psychotherapies have evolved. It includes like compassion focused therapy, then acceptance commitment therapy, where we give importance to acceptance and commitment towards a valued action. Then mindfulness-based cognitive therapy, which has both cognitive restructuring and elements of mindfulness. Then compassion-focused. So basically, all these third wave psychotherapies have brought about a change in the way that I have practiced initially. A simple CBT or mindfulness would bring about a change in the would bring about a change in the client. But now, as the as the society has changed, more and more capitalistic, we are becoming more and more like competitive. Two issues has come up. One is these psychological suffering among people because of the society, and the support system is very less, and also people are more exposed to trauma. Trauma, and are they have more knowledge or awareness of what they had gone through, and requires help in this stance. So cognitive mindfulness-based cognitive therapy involves factors from mindfulness, body scan meditation, cognitive restructuring, and relapse prevention technique. So what my stance is that we follow an integrative approach depending on the client, and focus on what needs to be required or done, and carry on the psychotherapy.
Very rightly said, Vidya. So as you've heard, 4 new trends in psychotherapies, like one on child and adolescent, trauma-based, mindfulness-based, online psychotherapies. So whatever is there, it's not that therapists practice only these areas. It's that we have to be expertise in all areas. We have to get expertise in all areas through reading, attending workshops, attending programs, and updating your own knowledge through evidence-based research. But whatever is there, the do's and don'ts are always important. So who governs it? So there is always a legal and ethical aspect that governs all kind of therapies. So Nimi would throw some light on the topic regarding legal and ethical aspects.
Thank you, Sonia. Good afternoon, everyone. I'm very happy to be here with my alma mater, maybe after a gap of 20 years. I miss my old auditorium because of this extravagant decorations. It was much natural maybe 20 years back. Anyway, let me come to the topic. Actually, Indian Psychiatric Society had formulated certain guidelines for conducting various psychotherapies in the year 2010. The aim of this guideline is to ensure certain ethical standard for the practice of treatment or psychotherapy by mental health professionals. So while we talk about the basic tenets of a good psychotherapist, the first and foremost thing is the competence of the therapist. A therapist should possess adequate skill, adequate training, and adequate knowledge and qualification to conduct a specific kind of psychotherapies. So there's an issue when we talk about this competence is the emotional competency of the therapist. That is, how much the therapist is aware of one's own emotional state while dealing with a client. Whether one's own personal issue is interfering in the process of therapy, then the therapist is advised to refrain from conducting therapy and seek personal help or personal therapy. Also, one is advised to either stop or terminate or transfer the client to another colleague or another expert. Also, it is mandatory to seek supervision if the therapist is finding very difficulties in the and check one's own emotional status too in the therapy sessions. And there are certain responsibilities a therapist possesses towards one's client, like maybe starting with proper assessment of the client, whether the client is fit or amenable for a counseling, or whether the person is amenable for a particular kind of therapeutic work, or whether he or she has to be sent for alternate kind of treatment like medication. And also the therapist should be able to draw a clear and realistic contract with the client where they should mention as much as possible in the first session itself what is the kind of work one is going to do, what are the roles and responsibilities of the therapist and the client, what will be the time taken for it, what will be the fee, what is the mode of payment. So clear contract should be made in the initial sessions itself. And take all possible steps to reduce harm to the client. I remember one girl came recently to me who is now 19-year-old, having a history of trichotillomania, that is compulsive hair pulling, since her age 10. She was taken to a clinical psychologist then, and he apparently told her that you should not do this. Then she was telling me, how can I do that? Because I don't have any control over it, and he's asking me to stop doing it. In the second session, she went and he said that, see, you are not doing it. I will give you injection. You should stop it. Afterwards, both the family members and the child was so upset and scared to go to any kind of, medical practitioners. And over a period of time, she herself searched and researched in the available means in the internet, and she learned that I have trichotillomania. This is a psychological issue. I should seek experts, and she went and met a psychiatrist, and psychiatrist thought that she would be benefited by psychotherapy, hence the referral came to me. So please don't do any harm to the child. If you are not confident about what you are doing, and if you don't know any particular area, please try to refer them to a expert in that area or a senior colleague. And as I said, seek regular supervision to enhance one's own skills, and also always try to promote independency and autonomy in the client so that their dependence needs should be reduced on the therapist. And therapist should avoid any kind of other relationship with the client, that is avoid any kind of peer relationship in terms of financial transaction or sexual contact, etc. And therapist is supposed to maintain confidentiality, which can be broken in certain cases. For example, if the person is suicidal, or if the person poses threat to themselves or others, or if the client is a minor, you are supposed to inform to the parents or the immediate guardian, or if none of them are available, to the law enforcing agencies. But it should be with the consent of the client. And in no way exploitation of the client is acceptable in terms of charging them extra, or charging them for other referrals or any kind of financial transactions. And when we talk, also therapist should keep a healthy boundary relationship with the keep a healthy boundary with the client, because there are two terms always occur in the literature, that is boundary crossing and boundary violation. Boundary crossing is not essentially very harmful, but violation is harmful, and that can exploit the needs of the client, such as maybe sexual or financial or dependency needs. So, how one should deal with the boundary is something like, one should always keep a, as soon as the therapy session is over, you can have a reflective session on yourself, what is happening with the client. For example, you can understand it is better in terms of when you discuss about the time of therapy you are scheduling. For example, if you are scheduling the session after your working hours or on a Sunday, so you should be careful. Why I have done this? Why I am not seeing the patient during my working hours? Okay, maybe next example, maybe the space. You are seeing the client in a public place or in other places than the therapist's office. So that is all indicating a kind of boundary violation from the part of the therapist. Also, payment. Maybe you are seeing them for free of charges. But of course, therapists can see the clients on pro bono basis, but it should be clearly mentioned in the therapeutic contract or an informed consent that you are taken in the initial sessions. Initially you are charging, afterwards you are not at all worried about whether they paid the money or not. You are continuing the session, despite that maybe the patient is not telling you about any financial constraints. So that is another red flag. You should remember what is happening between me and that particular client. Also, the kind of dressing which is very revealing, very exposed, seductive. So that is also a kind of boundary crossing from the side of therapist. Another very important aspect is self-disclosure. How much you can disclose. Self-disclosure is always welcoming in therapy, but how much and for example, whether it will help the client or not. Revealing one's personal information about myself will help the client or not, doesn't matter. Or if it just my need to express something. So that is one needs to be always keep in mind. So these are the certain things, I have a client, she's a long-term client in her middle age, has been seeing me initially offline. When COVID came, I changed it to the mode of online therapy. During the now I think I will see, this is my third year with her. She's telling me, she's demanding me to meet me in person and hug me. She's very demanding on that. I will come to a clinic and I need to hug you. I said, initially I was a bit embarrassed in fact. Why does she want to come and hug me in the middle of the session? She said that she started explaining that, you know how much the touch can soothe someone. Yes, it might be therapeutic for her, but I am quite uncomfortable. This is not the way I work. So I told her, this is not the way I work. I am not used to it. Then I think 3, 4, 5 sessions went on with that, hug, and then I think she understood that that is not going to happen with me, so she stopped. So this is how the, from the client side, they demand, or they send messages during non-working hours or during untimely, like in the middle of the night, or sometimes they keep calling unnecessarily. They just wanted to inform us, sending friend requests in the Facebook. These are some of the indication for boundary violation from the part of the client. So how we are dealing with this depends on the context in which we are working and the kind of work we are doing with the client. For example, if you are doing a pure analytical work or a psychodynamic work, it is mainly interpreted. We usually give the interpretation to that kind of behavior in terms of their needs in the relationship. But when you come to the other kind of therapies, like supportive, expressive kind of therapy, therapists need to be very cautious and careful how to, deal with those kind of boundary violations. There are many other ethical and legal aspects. I'm just, confining to these 2 points, and thank you for the time.
Thank you, Mimi. I think we have almost come to the end of the discussion. I would like to add few more points. As I work with the government sector, we are more guided by procedures that are guided by the Mental Health Act, procedures that are guided by the state government. So there we don't have any choice to say no. Whatever cases that comes to us, either you have to study the thing and implement it, or you have to take the help of somebody. So it's a kind of beg, borrow, steal. Somehow or the other you have to get the work done. And documentation is always an important part of psychotherapies. And whenever, usually the cases that are referred by the court, the cases that are referred by the child welfare committees, cases that are referred from police, when I entered service, whatever cases that we see in the newspaper, after a period of 1 week, we see them in the ward. So you don't know whether whatever things that you see in the newspaper, you get scared. Because on rotation basis, who is going to get the case worked up? That is always a crisis. So always growing is a part of being a psychotherapist. Learning never ends. So you have to continuously read up, look into evidence-based researches that are happening around, and improve yourself now and always. Even after several years of experience, I feel uncomfortable with many kind of cases, but there is no other way. You have to complete your work. Task completion is always important. Closing a file is always important. So how well you do your work, nobody judges you there. You have to judge it on your own. So as students, I will always tell you, when you hear these kind of therapies, when we were studying, we never thought that, okay, I'll become a trauma-based therapist. We never thought I'll go into EMDR. It's a journey. You go through several areas, you identify, okay, you are comfortable with this kind of therapy, you feel competent there, you feel somehow the click works on you, and then it all happens. So equip yourself with theoretical elements, go through research works, be updated about what is happening around, discuss with your partners, with your co-workers, with your teachers, and always keep in touch so that so that we can reduce the chances of going wrong. So after the end of the discussion session, I would like to invite questions from the viewers, from the students especially. Any questions that is related to whatever discussion that has happened, or anything. As we are alumni, you are free to ask any kind of questions related to professional issues. So kindly make use of this time and start with your doubts.
Thank you, ma'am. As we begin, I would like to thank our esteemed panel for this informative session. If anyone has any questions or if anyone requires further elaboration, please feel free to step forward. But before we begin, I actually had a little bit of a question for you, ma'am. Because you mentioned that psychology, it's a professional field, how we need to maintain a certain degree of professionalism when we're dealing with our clients. But when we come to a field that is more based on variables, far more than constants, because the human emotion is very variable in every aspect, in such a case, don't you think that an extreme degree of professionalism could possibly hinder or deviate the solution to the case?
Yeah, thank you for that question. And it's very valuable one because we are dealing with the emotions, so how come the professionalism can hinder the process? This is the definition of psychotherapy itself. It's a deliberate professional relationship established between two persons. So there is always, we should keep in mind that professionalism aspect, because this is not a personal relationship. Because this is what I spoke about in the time that is allotted to me. That can possibly harm the client. One of the main aim of psychotherapy is to make the person more independent. We always foster autonomy. So when there is a personal element come in between, there is a more chance that they become more and more dependent on us. Then it becomes a different kind of relationship. They started inviting us for marriages. They started inviting us for their other kind of things. But when you actually keep a boundary in such a way that there is time for availability for me, like weekly 15 minutes I am available to you, so that the person is learning in such a way that how to make use of me, the therapist, in that 15 minutes. That's a skill. It's another skill we are building up in them, so that they know, they learn to wait till the next session. They learn how to process the emotion within that 15 minutes, and in between the timing, between one therapy session and next therapy session, they are also trying to deal with by themselves, and they are giving us feedback, what happened. So this is how actually therapy works. Hope that helps.
It's clear. Thank you so much. We would like to invite further questions. Does anyone have any doubts?
Hi, it was a very insightful panel discussion. I mean, all things were covered. So my question is, what's your view on incorporating spirituality into psychotherapy? How is it helpful? What are the pros and cons?
Do you mean spirituality as in not specifically religiosity? I believe spirituality. I'm not sure if I'm an expertise in this, but I think one primary thing to keep in mind would be to be respectful of the other person's spirituality. I guess, if possible, to incorporate it into some aspect of therapy, even though, because I think it depends on your training also. We are, I think, largely very eclectic and process-based. I think a lot of us do that. So, I think, yeah, like I said, being respectful of the client and trying to incorporate it in such a way that even we can relate to it as well as the client can relate to it. Because if we ignore that part, I think a large part of our relationship is also, lost over there. I think the alliance breaks through. So bringing in spirituality, if it is of interest to the client, for sure, I think is a step, is a first step. I think somebody can talk.
I don't usually incorporate spirituality in my work personally, but literature says there are quite a lot of studies on how effective it is while applying in population of, especially with terminally ill people, life and people with, expecting their, death. Also, some amount in the old geriatric population. So it comes largely in the domain of positive psychology, and also it depends on how therapist personal inclination towards that aspect. So I think there are quite a lot of literature on that, and it has got its own effectiveness in certain kind of people.
If you go into depths of spirituality as well as to psychotherapy, there are portions where these two areas collide. So those areas we can make use of in our clinical settings. When Rollo says the purpose of psychotherapy is to set somebody free, that is what spirituality also does ultimately. So it can be, spirituality can very well be a tool to make your therapeutic, theoretical things, to put all these things. It can be a channel to put all these things into a client's mind. But at the same time, you should be able to handle it so comfortably, so smoothly, in such a way that nobody understands whether it is spirituality or whether it is psychotherapy. So it should glide like a smoothie, so that nobody knows what is happening. But at the same time, you hit some specific targets so that people get some kind of relief. And of course, it has a lot of therapeutic importance. Practicing is very difficult. Finding the right client with a spirituality psychotherapy combination is very difficult, but yes, it works a lot. And anybody else to add?
It's very important, yes, like Nimi and Swami all have said that spirituality is one of the most positive coping mechanisms, but it depends upon your diligence. Your spirituality should not be transferred to your client, because if you ask me, there are a lot of people who have come up to me because they've gone to a lot of psychotherapists and they felt their spiritual orientation is being actually transferred to them. And in the very first sessions, they make sure to say this, that we don't want this a spiritual orientation from us. So it is your diligence that based on your assessment with your client, whether you want to add this spirituality as a positive coping mechanism.
I'm working here in this college, the Department of Hindi. My question is, everybody, there is no chance for everybody for every time to visit a therapist. Sometimes if I feel low, if somebody feel low, what that person himself or herself should do or could do for their betterment, better mental health.
See, mental well-being and mental illness, it's on a continuum, right? So it's not necessary that you should have a psychiatric condition or a mental health disorder is to come to meet a therapist. So even if you have any distress or anything of emotional distress in nature, you can meet a psychotherapist. Now, there are certain things that we all can follow in our life, like mental health hygiene that needs to be followed. Your sleep, what you eat, your physical well-being, the physical activities that you do, and mood fluctuations are normal. But if you see that you are not able to come back to being yourself within a period of time, that is when you see that, okay, I'm not able to handle it. It's not like other times when I could come back. So what is going on with me? That is when you probably should think of meeting a mental health professional. Now, peer support and social support is something that also helps largely. But if you feel that you're not able to handle, then you should not shy away from meeting and taking a professional help, just like how we take care of our physical health. If you have a fever, you wait for 1 or 2 days and you see if you will be able to manage it. If not, you do not shy away from seeing a mental health professional, right? So it should not. So there's a lot of taboo around it. But we as mental health professionals should be the first one to break the taboo and reach out to the mental health professionals and then seek their support.
Any more questions?
Does anyone please step forward?
Good afternoon to any one of you. This is not a question, but I feel like something that can be included in the recent challenges. So during my internship time, a lot of cases that we got, be it depression, anxiety, or schizophrenia for that matter, had academic stress or failure as one of the precipitating factors. And it was very heartbreaking to see that it impacted them to such a level. Of course, there are other environmental factors that also add on to it, but the impact of academia was so heavy that it led to them not being able to function as most of us do. So I really feel like that should also include as one of our challenges that the youth or the studying generation faces, and maybe something that can be looked into not just in the sense of therapy, but also how we can make it much better for parents and students to understand that identity and academia are not the same.
I think the what she said right now, it just reminds me like the college days. I'm just going 20 years back down the lane. How I was in this college, doing my graduation 3 years. If you ask my teachers who are sitting here with this nice images, I was not a very academic person, but I'm more of an extracurricular activity person. So this stage is not something where I used to actually do any kind of what we are right now sitting and doing. So to her question, to her answer, is that, yeah, like rightly said, it's not what your academic marks, none of these certificates from your school to your college, the high score, what you've got, is not making you as a person what you are. But the deeper meaning and the sense of orientation that you start getting to what you want to be and what you want to do for the society is what makes you this person. So if you ask me, yes, definitely I was passionate about this field, but at the time, yes, I did study, I did score, I did pass out. As we go on, alongside what I learned and enjoyed is the kind of activities. So when we're doing all this, there was a lot of psychological development that was happening through to make me where I am sitting right now. So I think people are still, especially with this competitive world, this has become a great stress factor. So please don't identify yourself is what marks you get. Tomorrow, after another 10 years or 5 years down the lane, you must be sitting here to give a talk on it. Thank you.
I think when you mentioned that point also, that reflection that you had, many of my clients who were in 11th grade, 12th grade sort of popped up into my mind, because there's a lot of pressure, like you said, on these students, and they come to us with that burden, and their teachers their parents might not be, forceful about the fact that they need marks, but I think it's this general cultural, social expectation that you need marks, and many of these sessions are with these children who are crying throughout the session. So it's very heartbreaking to see, but also I feel like there is this big, I think it happens because there's a lot of expectation and a lot of work that's being done in schools, and there's a lot of burden. So I don't think it was like that when we were in school. I don't remember it being that stressful, but I think Nowadays, children have exams and models and pre-models and pre-models, and so I don't know. I think there is a bigger need to also go into the school system to shift the mindset of teachers. Of I think the expectations that come with that. Yeah. So thank you for that.
Thank you very much. If anyone has any further questions or queries, please feel free to contact our panel or the program committee. Once again, I would like to thank you all for such an informative presentation.
I have a closing comment.
Sure, please, ma'am, please.
Keeping apart all these topics, കുറച്ച് നേരം മലയാളത്തിൽ നിങ്ങളോട് സംസാരിച്ചോട്ടെ. ഇത് ടോപ്പിക്സ് ഒക്കെ കഴിഞ്ഞല്ലോ. അപ്പോൾ പാനൽ ഡിസ്കഷൻ എപ്പോഴും ലെറ്റ് ദിസ് ബി എ സ്റ്റാർട്ടിംഗ് പോയിന്റ്. നിങ്ങൾക്ക് അലൂമിനൈസിൽ ഇത്രയും ഭയങ്കര ആളുകളെന്നല്ല, പക്ഷേ കുറച്ച് കാര്യങ്ങളൊക്കെ പറഞ്ഞു തരാൻ പറ്റുന്നവരാണ്. അപ്പോൾ വർക്ക്ഷോപ്സ് കോൺഫറൻസസ് അല്ലാതെ കോൺഫറൻസസ് ജസ്റ്റ് ഗിവ് യു ഓൺലി എൻ ഓവർവ്യൂ ഓഫ് തിങ്സ്. യു ഹാവ് ടു നോ സംതിങ് ഇൻ ഡെപ്ത്. വർക്ക്ഷോപ്പായിട്ടോ അല്ലെങ്കിൽ ക്ലാസ് ആയിട്ടോ ഒക്കെ വെച്ചാൽ കുറച്ചും കൂടെ നല്ലതായിരിക്കും ടോപ്പിക്സൊക്കെ അറിയാൻ. പിന്നെ ഡെഫിനറ്റ്ലി ഇൻറ്റേൺഷിപ്പ് പോസ്റ്റിങ്സ് നല്ലോണം ഹെൽപ്പ് ചെയ്യും. പിന്നെ ലൈബ്രറി, ഇപ്പോൾ നമ്മുടെ ഇൻറ്റേൺഷിപ്പിന് പലപ്പോഴും സ്റ്റുഡൻസ് വരുമ്പോൾ ഒരു ഫീൽ എന്താ വെച്ചാൽ ഈ ടെക്സ്റ്റ് മെറ്റീരിയൽസിനെയും ടെക്സ്റ്റ് ബുക്കിനെയും ഭയങ്കര സിമ്പിളായിട്ടാണ് കാണുന്നത്. എല്ലാവരും ഗൂഗിളിൻ്റെ പിന്നാലെയാണ്. അത് നിർത്തിയിട്ട് കുറച്ച് ടെക്സ്റ്റ് ബുക്സൊക്കെ വായിക്കാൻ പറ്റുക. തെറപ്പി നമുക്ക് വീഡിയോസിൽ കാണുന്ന പോലെയോ ഇറ്റ്സ് നോട്ട് ഈസി ആസ് വി ടോക്ക്. തിയറി മസ്റ്റാണ്. ഇഫ് യു ഡോണ്ട് ഹാവ് ദ തിയറിറ്റിക്കൽ ബേസിസ് യു വിൽ ഗോ റൗണ്ട്. തിയറി പറഞ്ഞത് മാത്രം ചെയ്യാമെന്നല്ല, ഏത് തിയറി ചെയ്യുന്നു എന്നല്ല, ബട്ട് തിയറി ഇല്ലെങ്കിൽ നമുക്ക് അടിതെറ്റും. സോ ഓൾവേസ് ബിക്കോസ് ലീഗൽ ഇഷ്യൂസ് വരുമ്പോൾ ഇഫ് യു സേ ദാറ്റ് സി ഐ ഹാവ് ഇതിലുള്ള ഇതാണ് ഐ ഫോളോ ദിസ് എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ നോബഡി ഈസ് ഗോയിങ് ടു ആസ്ക് യു എനിത്തിങ്. പക്ഷെ നമുക്ക് നമ്മുടേതായിട്ടുള്ള സ്റ്റൈല് ഡെവലപ്പ് ചെയ്യാൻ പറ്റും. അപ്പോൾ ഓൾവേസ് മേക്ക് യൂസ് ഓഫ് ദാറ്റ്. പിന്നെ പലപ്പോഴും നമ്മൾ ഓരോ പ്രോസസ്സ് കൂടെ കടന്നു പോകുമ്പോൾ നമ്മൾ അറിയില്ല എന്തൊക്കെയാണ് നമുക്ക് കിട്ടിക്കൊണ്ടിരിക്കണതാണ്. അപ്പോൾ ഇവിടുന്ന് പഠിച്ചപ്പോഴാണെങ്കിലും യൂണിവേഴ്സിറ്റി ഡിപ്പാർട്ട്മെൻറ്റിൽ പഠിക്കുമ്പോഴാണെങ്കിലും ഡെയിലി ലൈഫ് ഭയങ്കര ഹാപ്പി ആയിരുന്നു. നമ്മൾ രാവിലെ ക്ലാസ്സിൽ വരിക, സംസാരിക്കുക, ടീച്ചേഴ്സുമായിട്ടൊക്കെ നമുക്ക് ഭയങ്കര സ്നേഹമായിരുന്നു. ഇപ്പോഴും അതൊക്കെ ഉണ്ട്. നമുക്ക് എപ്പോഴും ആ ഒരു വാർത്ത നമ്മുടെ ഉള്ളിലുണ്ട്. അന്ന് പോയിട്ട് ഇപ്പോഴാണ് തിരിച്ചു വരണമെങ്കിലും എപ്പോഴും പ്രചോദി നമ്മുടെ വാർത്തായിട്ടുള്ളുണ്ട്. ഇതിൽ കൂടെ കടന്നു പോകുമ്പോഴേ അറിയുള്ളൂ നമ്മൾക്ക് എന്തൊക്കെയാണ് വന്ന് ചേരുന്നതെന്നുള്ളത്. അപ്പോൾ ഓൾവേസ് മേക്ക് യൂസ് ഓഫ് ദ സിറ്റുവേഷൻ, റീഡ് വെൽ. ആൻഡ് ഇത് അച്ചീവ് ചെയ്യുക എന്നുള്ളതൊന്നും ബുദ്ധിമുട്ടുള്ള കാര്യമൊന്നുമല്ല. ഡെയിലി സിലബസ് വളരെ കുറച്ച് കാര്യങ്ങൾ സിലബസിലുള്ളൂ. അതൊക്കെ പഠിച്ചു പോയാൽ തന്നെ നമുക്ക് ക്വാളിഫിക്കേഷൻസ് അച്ചീവ് ചെയ്യാവുന്നതേ ഉള്ളൂ. ടു ബി എ ഗുഡ് പേഴ്സൺ, ടു ബി ഗുഡ് അറ്റ് ഹാർട്ട്, ഷെയറിങ് യുവർ ലവ്, ബീയിങ് ഹാപ്പി, അതിലൊക്കെ ഫോക്കസ് ചെയ്താൽ തന്നെ ലൈഫ് ഇസ് വെരി സിമ്പിൾ. അപ്പോൾ ഫ്രം മൈ സൈഡ് ഐ എം വെരി ഗ്രേറ്റ്ഫുൾ ടു ബി ഹിയർ, വെരി താങ്ക്ഫുൾ ടു ബി ഹിയർ. ഞാൻ വന്നത് മിലോസ് വിളിച്ചുകൊണ്ട് മാത്രമാണ്. അല്ലെങ്കിൽ ഡെഫിനറ്റ്ലി വരില്ല. സെക്കൻഡ് റീസൺ വിദ്യ നിമ്മയുള്ളത് മാത്രം. അപ്പോൾ ടീച്ചർ വിളിച്ചുകൊണ്ട് മാത്രമാണ് വന്നത്. വീട്ടിൽ ചെറിയ കുട്ടികളുണ്ട്. ഭയങ്കര കോംപ്രമൈസൊക്കെ ചെയ്തിട്ടാണ് എങ്ങനെയൊക്കെയോ രാവിലെ ട്രെയിനിൽ ഞാനിവിടെ എത്തിപ്പെട്ടത്. അപ്പോൾ ഇങ്ങനെ വിളിച്ചാൽ വരാൻ സ്റ്റുഡൻസ് എപ്പോഴും പ്രചോദനയിലുണ്ടാവും. അപ്പോൾ ഓൾവേസ് മേക്ക് യൂസ് ഓഫ് യുവർ സീനിയേഴ്സ് ആൻഡ് ഇറ്റ്സ് എ ഗ്രേറ്റ് പ്ലഷർ ടു ബി ഹിയർ, ടു ബി ഓൺ ദിസ്. ഇവിടെ ഇരിക്കുമ്പോഴേ മനസ്സിലാവണം കേട്ടോ, ഏറ്റവും പിന്നിലിരുന്നാലും ഇവിടെ നിന്നൊക്കെ കാണാം. നമ്മൾ വർത്താനം പറയണതും ഇറങ്ങി പോകണം, പുറത്തേക്ക് നോക്കിയിരിക്കുന്നതും. അത് ഞാൻ അങ്ങനെ ആലോചിക്കുക, നമ്മളൊക്കെ ഏറ്റവും പിന്നിലിരുന്ന് എന്തൊക്കെ കാണിച്ചു കൂട്ടിയിട്ടുണ്ടാകും. ഇവിടെ ഇരിക്കുമ്പോഴത് അറിയാം. അവിടെ ഇരിക്കുമ്പോൾ വിചാരം ഒരു 5ാമത്തെ സീറ്റിൻ്റെ അപ്പുറത്തേക്ക് ഒന്നും കാണുകയാണ്. അപ്പം അങ്ങനെ കുറേ തെറ്റിദ്ധാരണകളൊക്കെ ഇവിടെ ഇരിക്കുമ്പോൾ മാറി കിട്ടി. ആൻഡ് സോ വാം ടു ബി ഹിയർ. താങ്ക്സ് എ ലോട്ട് മാം, ആൻഡ് താങ്ക്സ് ടു ദിസ് ഇൻസ്റ്റിറ്റ്യൂഷൻ ഫോർ വാട്ട് വി ആർ ഡൂയിങ്. ഇനി ക്ലോസിംഗ് റിമാർക്സ് ആയിട്ട് ബാക്കിയുള്ളവർക്ക് എന്തെങ്കിലും പറയാണ്ടെങ്കിൽ ഷെയർ ചെയ്യാം.
I would also like to thank my teachers for this opportunity. ഞാൻ ഈ സ്റ്റേജിലാകെ ഡാൻസ് കളിക്കാനും പാട്ട് പാടാനും ഡ്രാമയിൽ കയറിയിട്ടുള്ളൂ. So to stand here, to sit here in a professional capacity is a huge honor, and I think it's the same for all of us. So thank you for this opportunity.
Thank you everyone. It was an honor to have you all on the panel. We sincerely appreciate your invaluable contribution as a moderator and the panelist.
I now invite our principal, Dr. B.O.M.S Chako, to present a memento to our moderator, Dr. Soumya K. Sukumaran. Sir, please.
സാറിന് യൂണിഫോം കിട്ടിയ
I also invite Father Dr. Joseph Anto, Clinical Psychology President, TCPF President, to present a memento to Dr. Vidya Kennedy. I invite Sister Jinsi PD, Clinical Psychologist, Ansa Hospital, to present a memento to Ms. Sharika Shah. I invite Sister Jinsi PD, Clinical Psychologist, Ansa Hospital, to present a memento to Ms. Nimi Michael. I invite Dr. Salish, Clinical Psychologist, to present a memento to Ms. Sri Lakshmi ES. Last but not the least, I invite Ms. Nita Thomas to present a memento to Ms. Shruti Yani. Thank you.
Once again, thank you everyone. Now the house will be adjourning for a short tea break. Please enjoy the refreshment.